Good evening, everyone. Our seminar today is going to be about incisions, flaps, and suturing by Faisal, Alhuwaizi, and Dr.Abdullah, Awad. Before we start, I would like to welcome Dr. Sarmad, our supervisor, and my student colleagues. The first topic here is incisions. So what are incisions? Incisions are a way to get access to an operating site, which is obtained by cutting skin or mucous membrane, and by dissecting through this incision to elevate a flap. We basically have two types of instruments that we use in combination to make an incision. The first one is the blades, which are called scalpels, and the second one is the scalpel holder. As you can see, there's a variation of blades which differ in size and shape, and we have only one scalpel holder that we use intraorally, which is number 3. Most commonly used blades in dentistry are these, number 11, 12, and 15. We mostly use these because of their size. Their size is relatively small, which makes them good for intraoral use. There are 3 major ways to hold a scalpel. The first and most important one is the pencil grip, which most dentists use because it allows maximal control. We also have the fingertip grip and the palm grip, which are less common in use. Types of incisions. We basically have 6 major types of incisions, which we will discuss briefly. The first one is the stab incision. We use blade number 11 for this incision. It's used for incising an abscess, whether it was extraorally or intraorally. Now we have the straight vertical incision, which is a very simple one. It basically goes parallel with the long axis of the tooth. But here we don't start from the papillary margin, we go a little bit to the side. And the reason for that is if we start from here, after healing and after gingival recession, we'll get a triangle space here, which is black, which would be an empty space, which is very anesthetic. 3 here is straight horizontal incision. It's also a very simple incision of the edentulous ridge, mostly used for implants or removing of an impacted tooth. Number 4 is intrapapillary or sulcular incision. As you can see, we insert the blade into the space, into the sulcus, between the tooth and the gingiva, and we make a scalloped incision. Then we separate it. We have a variety of reasons to make this incision, which we will discuss in the flaps section. Number 5 is the Y and double Y shaped incision, used to remove torus palatinus, usually, and as you can see, it's a very wide incision. Number 6, which is the last incision, is for lower third molar. We basically have 2 major types to make an incision here. Both of them are started with a horizontal incision above the third molar, then a sulcular incision around the buccal gingiva of the 7. But here in modified words incision, we go downwards with a vertical incision. With this technique, we go on sulcular again, around the buccal gingiva of the 6. Principles of incision making. Use sharp blades of proper size. Vital structures must be avoided, like blood vessels and nerves. Blades should be held perpendicular to the surface of the incised. Perform a firm, continuous stroke in order not to get back and forth movement or tearing. Incisions should be properly placed, incise over healthy bone and attached gingiva, in order to get a well-supported incision site. Last but not least is the scalpel insertion and removal. When we insert a scalpel, we hold it near the blade, and then we insert it with an angle, and we keep sliding until we hear a click That's when we know that it's well supported. When we remove it, we start from the opposite direction, from the base of the blade, and then we free it from the lock and slide it in the opposite direction. Our second topic here is flaps. Flaps are reflected mass of soft tissues to expose the underlying bone, to remove impacted teeth, roots, or any pathological lesions. The purpose for a flap is to obtain adequate visualization and access to the underlying structure or lesion without traumatizing surrounding tissues. We have these are the mostly used instruments for opening a flap: the Howarth periosteal elevator and Molt number 9. Both of them are double-ended. Here in the Howarth we have one end which is used for flap retraction, and the other end is used for pushing to open the flap to separate the periosteum from the bone. In the Molt we have one broad end which is blunt and one sharp pointy end. Types of intraoral flaps. We have 7 types, which we'll discuss also briefly. The first type of flap is the envelope flap. Here a circumferential incision is done around several teeth, with the affected tooth being in the middle. The reason for that is to prevent the tearing of the flap during separation, as in the case of an exposure of an impacted canine for orthodontic treatment or for extraction, or for extraction of a deep retained root. The second one is the two-sided or triangular flap. Here we use a combination of a circumferential incision with a vertical one in order to reach a more apical location, as in the case of an episectomy. The third type is the three-sided flap. Here we have a combination of a circumferential flap with 2 vertical flaps in order to get a better access to the apical area. As you can see here, the base of the flap is broader than the gingival portion of it in order to get a better blood supply and better healing. Thank you, that was the end of my part, and I would like to invite my colleague Dr. Abdullah to complete the seminar.
Thanks to my colleague Dr. Faisal Akram. So I will continue the types of flaps. Okay, the semilunar flap. We start with a bow-shaped incision with the convexity toward the teeth, and the lowest point of the incision must be at least 0.5 cm from the gingival margin so that the blood supply is not compromised. The indication in episectomies, removal of small cysts and root tips. The disadvantage is the possibility that the incision is being performed over the lesion due to miscalculation and the limited visualization. The advantage: the semilunar flap is far from the gingiva, so it won't lead to gingival recession. The submarginal flap is same as the semilunar flap, but with a different design. As we can see, the flap is scalloped in shape to mimic the gingival margin. This will lead to better visualization and easier suturing. The pedicle flap mainly used to close the oro-antral communication. In this type, we take the flap from the adjacent tissue, either buccally or palatally, or the bridge type, which we take the flap from the same ridge in case the patient has an edentulous space. The last flap design is the Y and double Y flap. In the Y flap, we do long vertical incision along the midline of the palate with 2 anterolateral incisions to remove small exostoses or the torus palatinus. And in the double Y, we add 2 posterolateral incisions in case of bigger exostoses. The most common complications of the intraoral flaps. First one is the flap necrosis. Flap necrosis, the main reason of flap necrosis is the infection due to contaminated instruments, especially during the suturing. Also, if we did bad flap design and compromise the blood supply, it will lead to flap necrosis. Flap dehiscence Flap dehiscence means healing of the incision with separated margins. The reason either the soft tissue were unsupported or the suturing was under tension. The third complication is the flap tearing due to over retraction. The last and most important complication is the trauma to vital structure. We have to take in consideration the vital structure of the mandible, which are the mental nerve and the lingual nerve, and in the maxilla, the greater palatine nerve and vessels of the palate. In order to avoid this type of complication, we should have a good knowledge of the head and neck anatomy. The last topic of our seminar is the suturing. So what is the purpose of suturing? The primary objective of dental suturing is to position and secure surgical flaps in order to promote optimal healing, to approximate soft tissue edges, to cover the surgical field, or ligate blood vessels. The suturing instruments, we have 5 main suturing instruments. The first two is the needles and needle holder. There are many types of needles, but we will specify the most commonly used in dentistry, which are the half circle and 3/8 of circle. The needle holder has a small blade with crisscross serrations and sometimes a groove in the middle. We should differentiate between the needle holder and the artery forceps, which has longer blades and parallel serrations. The suture. We have many classifications. First, the gauge range from 10 to 10, and higher the number correspond to the thinner and more delicate the suture. The other classifications is the natural and synthetic, the monofilament and multifilament, the resorbable and non-resorbable. The most commonly used suture in dentistry is the silk, with the gauge range from 30 to 60. The scissors for cutting the suture, and tissue forceps to grasp the flap during the suturing. We must ensure that these instruments are sterile before the suturing. Principles of suturing. The needle should be grasped with needle holder 1/3 from the swashed ends. Needle should be perpendicular to the surface being entered and tissues. The needle should not be forced through the tissues. The point of the needle should not be grasped with an instrument. Suturing from mobile to relatively fixed tissues. The mobile tissue should be grasped with tissue forceps. The needle should be held in the palm of the operator hand during tying the suture. Sutures should be tied only tight to gently approximate the wound edge. Suturing techniques. Mainly we have 5 suturing techniques, but before I start we will see a short video to learn how to knot the suture in order to understand these techniques.
Before we get started showing you different suture techniques, I want to show you a basic instrument tie. This can be used with any of the suture techniques that you will learn. Once the suture is placed, you'll have a short end and then a longer loop end. Your needle driver should be placed directly between the two, and then we will do a surgeon's knot. You'll wrap the longer end twice around the needle driver, grab the smaller end, and pull it to the opposite side. And what will happen when you pull it to the opposite side, it will square the knot, and you can see how square the knot sits down. Now, because it's a surgeon's knot, it'll sit unless you pull up on it. So don't pull up on it. Place the needle driver between the two, the short end and the loop end. Now you're going to loop it around only once. Grab the short end and then bring it to the opposite side. Again, squaring the knot. And don't pull up on the suture until you just get it down, and then you can tighten it. And now it's locked in place. I recommend at least 3 throws, instrument between, bring the small to the other side.
In the interrupted technique, we leave a 0.5 cm between each suture, also 0.5 cm from the margin. It is the easiest and most commonly used technique. Each suture has its individual notes, and the notes should be on the same side. The simple continuous technique is the same as the interrupted technique, but instead of cutting the suture, we continue our loops till the end of incision with a knot at the end. It is easy and fast, but the cons of this technique: if we cut one part of the suture, we will lose all of it, either by the surgeon itself or by the patient during the cleaning or functioning. Matrix technique. First we have the horizontal matrix technique. It is the strongest type of sutures, very far away, 8 mm from the edge. Indications: large distance between tissues, bone grafts, implants, and the closure of extraction sockets. Advantages: good for hemostasis, less prominent scarring. The disadvantages: leave a gap between the flaps and it is difficult to remove. The vertical matrix technique indicated where the wound tends to evert. Evert معناها الفلاب ينطوي لي برا أو لي جوا، خاصة في منطقة الرقبة neck. The last technique is the figure of 8 technique. It gives us rapid closure and is indicated in the extraction sockets and the adaptation of gingival papilla around the tooth, but due to its orientation it is difficult to remove. Thank you, dear colleagues and Dr. Sarmed, for your kind listening.